I want to start today by asking you to think about a word. The word is fitness. When I say that word, what pops into your head? Are you thinking about, I don't know, a gym membership you haven't used since January?
Oh, maybe. Or, you think of elite athletes, performance.
Right. That guy at work who runs ultramarathons and, like, won't stop talking about his splits during lunch?
Yeah, for most people, it's associated with vanity or sports or maybe just general wellness. I want to lose 5 pounds or I want to run a 5K.
Exactly. For most of us, for most of the world, fitness is a hobby. It's a lifestyle choice.
Right.
But we have a stack of research on the table today that it completely flips that definition on its head. We're looking at a very specific group of children where fitness isn't about gym class. It's not about making the varsity team. It is, and I mean this literally, it is a vital sign.
It's a crystal ball.
A crystal ball, that's a great way to put it. It predicts how long they're going to live.
Yeah, we're talking about children with congenital heart disease or the CHD. And for this group of kids, cardiorespiratory fitness, which is just a fancy way of saying how well their heart and lungs deliver oxygen to their body.
Right.
That measure is the single strongest predictor of morbidity and mortality down the road.
It's the engine gauge.
It is the engine gauge.
Yeah.
A perfect analogy. If that fitness number drops, the risk of heart failure, of hospitalization, and ultimately of death goes up.
Okay, so here's the tension. This is what anchors our deep dive today. Imagine for a second you're a parent of one of these kids.
Okay.
You take your child to the cardiologist every year. They do a stress test. The doctor comes in, looks at a chart, and says, great news. Your son is in the 50th percentile. He's average. He's doing fine.
And you feel this wave of relief.
A huge sigh of relief. You go home. You let him play soccer. You think everything's on track.
Well, what if that chart was wrong?
What if the ruler the doctor was using was broken? Or maybe not broken, but calibrated for a completely different game. That is the entire premise of the paper we are unpacking today. It suggests that for years, maybe even decades, we might have been grading these kids on a curve that made them look healthier than they actually are.
It's the classic apples to oranges problem.
Exactly.
But with stakes that are just immeasurably higher. We've been comparing results from treadmill tests to standards that were created using bicycles. And today we're going to find out why that is a massive physiological error.
We are diving into a really landmark study. It's titled Reference Standards and Diagnosis-Specific Trends in Cardiorespiratory Fitness in Pediatric Patients with Repaired CHD.
That's a mouthful.
It is, but it's important. It comes from a team at the Ann and Robert H. Lurie Children's Hospital of Chicago, Garrett Griffith, Alan Wang, and Kendra Ward. And this was just published in Cardiology in the Young in 2026.
And it's worth noting, just to set the stage, Lurie Children's is a tertiary care center.
What does that mean exactly?
It means they see the complex cases, the stuff your local community hospital might not handle. They're a major referral center. So when they publish a data set of nearly 900 kids, I mean, the entire pediatric cardiology world sits up and listens.
Okay, so our mission for this deep dive is pretty straightforward, even if the medicine gets a little complicated.
Yeah.
First, we're going to find out how fit these kids with repaired hearts actually are. Second, we're going to throw out those old bike charts and look at the first ever treadmill-specific benchmarks for 10 different heart conditions.
Which is huge, a total game changer.
And third, we are going to talk about a phenomenon that when I was reading this, I found it, honestly, pretty terrifying. They call it the late teen slide.
It's a distinct drop-off.
Yeah.
It's like a cliff that some of these kids just seem to walk off of right around the time they're finishing high school.
A cliff is a good word for it, but before we get to the cliff, we have to understand the ruler. We have to talk about the stress test itself and why it matters so much.
Let's do it.
Let's get into the setup. I think for a lot of us, a stress test is just exercise. You know, you get on a machine, you get your heart rate up, they measure some things. Why does the method matter so much? Why is a stationary bike so different from a treadmill?
It did. It really comes down to biomechanics. And more importantly, what is it that actually limits your performance?
Okay.
Think about the last time you rode a bicycle up a really steep hill.
Try not to do that. But okay, yes, I can imagine the pain.
What's the first thing that forces you to stop? Is it that you're gasping for air and your heart feels like it's about to explode out of your chest?
No.
Or is it that your thighs are on fire?
Oh, it's the thighs. 100%. It's the quads. They lock up. It's that burning sensation, the lactic acid. My legs quit way before my lungs do.
Precisely. That is what we call local muscle fatigue. On a cycle ergometer, that's the stationary bike they use in a lab, The test is very often limited by the leg muscles giving out before the cardiovascular system, the heart and lungs, reaches its true maximum potential.
So you hit a ceiling, but it's a muscular ceiling, not a cardiac one.
You've got it. Your legs are the weak link in the chain, so they break first.
Okay, so if I'm trying to measure your heart's maximum ability to pump blood, the bike might sell you short because your legs just can't keep up.
It sells you very short. Now let's switch to a treadmill. When you're running or even just walking up a steep incline, that's a weight-bearing exercise.
Yeah.
You're carrying your own mass.
Right.
You're using your calves, your hamstrings, your quads, your glutes. Your core has to stabilize you. Your arms are pumping.
The whole body. It's a systemic demand.
Exactly. The whole body is screaming for oxygen. And because you are recruiting so much more muscle mass, the demand on the heart and lungs is significantly higher. The heart has to pump harder and faster to supply the whole system.
And so the treadmill test gives you a higher number.
It gives you a much higher VO2 peak.
Yeah.
That's the peak volume of oxygen your body can utilize. It's the gold standard for aerobic fitness. And on a treadmill, that number is almost always higher than on a bike.
So here is the trap. And I want to make sure I've got this right because this is the crux of the whole study.
It is.
For decades, a lot of the reference data, the charts that say what's normal for a 10-year-old boy or 14-year-old girl, that data came from bike tests. It
did, because bikes are, they're easier to standardize in a lab. They're a bit safer. You don't have kids falling off a treadmill as easily. So we have all this historical data on bikes.
The doctors, especially here in the U.S., they love the treadmill. They love the Bruce protocol.
It's the standard of care.
So a kid with a repaired heart, let's say a 12-year-old with a condition called tetralogy of Fallot, he gets on a treadmill for his annual test. He runs his heart out. He gets a score of, let's say, 40, a VO2 peak of 40.
Okay, a solid score.
But then the doctor goes to the bookshelf, pulls down a binder, and looks at a chart based on bike data. And on that bike chart, the average for a healthy 12-year-old is, say, 35.
So the doctor sees this kid's 40 against a standard of 35 and thinks this kid is an athlete. He's above average. He's in the 75th percentile.
But it's a mirage.
It is a complete illusion. It's statistical malpractice almost. You're comparing a test with a naturally high ceiling, the treadmill, to a benchmark with a naturally low ceiling, the bike.
Of course the kid looks good.
Of course. It's like taking a test in your native language and being graded on a curve for people who are just learning that language. Yeah. You're going to look like a genius, but it doesn't mean you are one.
And the danger here isn't just academic. It's not just about getting the numbers right.
No, not at all.
If you tell a parent their kid is in the 75th percentile, they relax. They might stop worrying about diet. They might start pushing for that extra walk in the evening or signing him up for another sport.
You've given them a false sense of security.
A completely false sense. Because if you used the right ruler, a treadmill-specific ruler, that same kid with a score of 40 might actually be in the 25th percentile.
And that puts them in the danger zone for future heart failure. It means they're already behind the curve. That is why Griffith and his team at Lurie Children's decided enough was enough. They said, we need a treadmill standard for treadmill kids.
And they went big. This wasn't a small study. They pulled data from 2004 all the way to 2022.
18 years of stress tests.
An incredible amount of data. They ended up with 887 patients.
Which, in the world of pediatric research, is a massive cohort. I mean, you usually see studies with 50 kids, maybe 100. Nearly 900 gives you real statistical power to draw meaningful conclusions.
I was reading through the methodology, and I really appreciated how strict they were about who got into this study. They used this term contemporary cohort. Now, usually contemporary just means modern, right? Like contemporary art. But here, it's actually a very important surgical distinction.
It's absolutely crucial because pediatric heart surgery has changed so radically in the last 30 or 40 years. We'll take a condition like transposition of the great arteries, or TGA. If you were born with that in, say, 1985, you got a surgery called an atrial switch, the mustard descending procedure.
Okay.
They basically rerouted the blood flow at the top of the heart inside the atria. It worked, it saved lives, but it left the right ventricle doing the job of pumping blood to the entire body.
Which it's not designed to do, right? The right ventricle is supposed to pump to the low-pressure lungs.
Exactly. It's a thin-walled chamber. It's not a workhorse.
Sure.
So those patients often went into heart failure by their 30s or 40s.
So what do they do now?
Now, if you're born in 2010, you get an arterial switch. The surgeon literally cuts the great arteries, the aorta and the pulmonary artery, and swaps them back to their correct positions.
Wow.
The plumbing is restored to be near normal. So the authors of this study, they threw out all the data from the old atrial switch patients.
So they're only looking at modern outcomes.
They only wanted the data to reflect the kids we are seeing in clinics today. And they did the same thing for the Fontan patients. Those are the kids with single ventricle hearts. They kicked out the old atriopulmonary connections and only kept the modern lateral tunnel or extracardiac connections.
So this data set is clean. It's not being muddied by surgical techniques that are essentially, well, extinct.
It's a gold standard for the modern era of congenital heart surgery.
Okay, one more detail from the methods that I loved. They made sure these kids were actually trying their hardest on the treadmill.
Yes, this is so important.
They talked about the RER, the respiratory exchange ratio. Can you explain that to me like I'm 5? Or maybe like I'm a tired teenager on a treadmill who wants to quit.
Okay, so when you breathe, you take in oxygen, O2, and you breathe out carbon dioxide, CO2.
Right.
When you're just walking or jogging lightly, that ratio of CO2 out to O2N is pretty balanced, usually less than 1.0. But when you start sprinting, when you hit that wall where you can't talk anymore, your body switches to anaerobic metabolism.
It's running out of oxygen.
It is. So it starts producing lactate or lactic acid. And to clear that acid from your blood, your body has to buffer it. And a byproduct of that is a ton of extra CO2 that you have to breathe out.
The hyperventilation phase, that panting.
That's it. Exactly. And when the ratio of CO2 you breathe out to the O2 you take in goes above 1.10, we know physiologically that you have maxed out. You aren't phoning it in. You have pushed your body to its absolute limit.
So they only included tests where the kids hit that 1.10 mark.
That's right. No submaximal efforts allowed.
Okay. So we have 887 kids, all with modern repairs, all running until they basically can't breathe anymore. Let's get to the big reveal. Let's look at the results. When you zoom all the way out across the entire group, how did they do?
Across the whole group, the average fitness, the average VO2 peak, was 85.9% of what you would expect from a healthy age-matched child.
85.9%.
Yep.
So if this were a math test, that's a solid B.
It's a B, maybe a B minus.
Yeah.
It's officially classified as low normal.
Low normal?
It means that, on average, a kid with a repaired heart defect has about 15% less aerobic capacity than the kid sitting next to them in algebra class.
Yeah.
So they aren't failing, but they are definitely operating with a smaller engine.
But, you know, heart disease is such a big, generic bucket. It includes everything from a tiny hole in the heart that was patched in infancy to a kid who is literally missing half their heart.
That's right. The average hides all the nuance. It's like, if you take the average net worth of a billionaire and a homeless person, you get $500 million.
Right.
That number doesn't tell you very much about the reality of the homeless person.
So let's break it down. The study stratified these kids into 10 specific diagnostic categories. I want to walk through them, almost like a tier list, from highest fitness to lowest.
Let's do it.
Okay, let's start at the top, the near normal group.
Yeah.
Who are the valedictorians of the CHD world?
The top tier is really dominated by the septal defects, specifically atrial septal defects, ASD, and ventricular septal defects, VSD.
These are the holes in the walls between the heart chambers.
Exactly. And once you patch that hole, either with a device or a surgical patch, the heart is, for the most part, structurally normal. The 4 chambers are there, the valves are there, the plumbing is correct.
And the data really bears that out.
It does. The ASD-VSD group scored 94.5% of expected fitness.
94.5%. That's basically within the margin of error for normal.
It is statistically indistinguishable from the general population in many studies. If you have a child with a repaired VSD, there's no physiological reason they can't be an elite athlete. There's no lid on their jar.
That's incredible news for those families. Sitting right below them, still in that top tier, we have coarctation of the aorta at 93.6% and aortic valve repair at 92.7%.
Again, you can think of these as plumbing fixes. Coarctation is a narrowing of the main pipe coming out of the heart, the aorta.
Like a kink in a hose.
A kink in a hose. The surgeon just widens the pipe and the flow is restored. The aortic valve is the main exit door from the heart. You fix the door so it opens properly and the blood leaves easily. The heart muscle itself, the ventricle, was never really the primary problem.
So the takeaway for parents in this top tier, the ASDs, VSDs, cohorts, aortic valve repairs, is pretty fantastic. Your kid is, for all intents and purposes, physically peer equivalent.
Yes. The message is, don't hold them back. Let them run. They have the hardware to compete.
Okay, now we get to the middle tier. And this is where I was genuinely surprised. The first group in this middle section is transposition of the great arteries, TGA. They scored 90.5%.
Which is just astounding.
Why is that astounding? 90% sounds like a great score, an A-.
It is a great score, but you have to remember what TGA is. It is a major critical heart defect. These babies are born profoundly blue. Deeply cyanotic. The plumbing is completely backward. The body blood goes back to the body, and the lung blood goes back to the lungs. Without emergency intervention and then surgery in the first days of life, they don't survive.
Okay.
So to see these kids who underwent massive open-heart surgery as tiny neonates performing at 90.5% of a healthy peer, I mean, that is the victory of the arterial switch operation we talked about earlier.
It really validates that entire shift in surgical technique.
It absolutely does. In the old days with the atrial switch, TGA kids were often told to limit their activity. They were fragile now. They're running at 90% capacity. It's a medical triumph.
Also in this middle tier, we have pulmonary valve repair, which came in at 88.1%, and then tetralogy of Fallot at 85.6%.
And that 85.6% is interesting because it's almost identical to the overall average for the whole group, which was 85.9%.
So tetralogy of Fallot is like the quintessential average CHD patient.
Yeah. In many ways, yes. It's the most common cyanotic heart defect, the classic blue baby syndrome.
Yeah.
And this data shows they are functional, they can and should play sports, but they do have a bit of a ceiling. They're operating at about 85% capacity compared to their peers.
Okay, so now we have to descend into the lower tier, the groups that show a more significant reduction in fitness.
Right.
And this is where the physiology gets really interesting for me. I expected the single ventricles, the Fontans, to be at the very bottom, but right above them there was another group, tricuspid and mitral valve repairs.
Yes. This group scored 81.3%.
Why? I mean, we just said the aortic valve kids were scoring over 92%. Why is a problem with the tricuspid or mitral valve so much worse? A valve is a valve, isn't it?
Oh, not at all. It's all about location, location, location.
Okay.
The aortic valve is the exit door from the main pumping chamber. The tricuspid and mitral valves, on the other hand, are the entrance doors into the pumping chambers.
They're the intake valves.
They are the intake valves. And if your intake valve is stiff or too narrow, that's called stenosis, or if it leaks backwards, that's regurgitation, then you can't fill the heart chamber properly.
Wow.
And here's the golden rule of cardiology. You can only pump out what you take in. It's called Starling's law.
So if the filling is impaired, the output is always going to be impaired.
No matter how strong the heart muscle is, if the chamber's only half full when it squeezes, the output is low. That's why these kids struggle more than the aortic valve kids. It's fundamentally a filling problem.
That makes total sense. It's like trying to fire a water cannon, but the hose feeding water into it is kinked.
That's a perfect analogy. And sitting right there with them in that same ballpark are the double outlet right ventricle, or DORV, and truncus arteriosus kids. They're hovering around 80.5%.
And those are just more complex anatomies.
Much more complex. These are often mixing lesions. They require multiple surgeries, often involving conduits or tubes that can wear out. There's just more scar tissue, more residual hemodynamic inefficiency in the system.
And finally, we reach the bottom of the chart. The most complex physiology. The single ventricle patients. The Fontan circulation.
The Fontan. This is the palliative surgical strategy for kids who are born with essentially half a heart. Conditions like hypoplastic left heart syndrome or tricuspid atresia.
The study split them into two groups. Right ventricle dominant and left ventricle dominant. I would assume left is better because the left ventricle is the powerhouse of the body, right?
You'd assume that, and historically that has been the thinking. But in this treadmill data, the difference was negligible.
Really?
The right ventricle dominant group scored 75.7%. The left ventricle dominant group scored 74.7%.
Wow, so it's basically a wash. They were both sitting at roughly 75%.
Which is, I mean, let's just pause on that number for a second. Think about what 75% means in the real world. It means these teenagers are navigating high school sports life with 3/4 of the engine power of their friends.
So when their friend runs up a flight of stairs and is fine, they might be winded.
They might be very winded. Why is that? What's the core problem with the Fontan circulation?
Is it just that they only have one pump instead of two?
That's part of it. But it's more about the physics. In a normal heart, you have a pump, the right ventricle pushing blood to the lungs.
Right.
In a Fontan, there is no subpulmonary pump. The blood flows to the lungs passively. It's driven by the pressure in the veins and the negative pressure you create in your chest when you breathe in.
So it's like a gravity feed system. Or a siphon.
Essentially, yes.
Yeah.
And because there is no pump pushing blood into the lungs, You can't ramp up the flow during exercise the way a normal heart can. You hit a wall. It's called preload failure. The heart is beating fast, it's ready to pump, but the blood just can't get back to it fast enough to refill it.
So they hit a very hard ceiling on their cardiac output.
They do. But, and this is a huge but that the authors emphasize, we have to look at the histograms.
The distribution charts, the bell curves.
Yes. The average was 75%, but the spread, the range was enormous. The standard deviation was nearly 18%.
What does that mean in practical terms?
It means that while the average is 75%, there are some Fontan kids scoring down in the 50s, but there are also Fontan kids scoring up in the 90s.
Wait, really? A kid with literally half a heart can have a fitness level that's 90% of a healthy peer.
Yes. It's rare, but it happens. And that tells us something incredibly important.
What's that?
It tells us that biology is not destiny. Anatomy is not the only factor. If a Fontan patient has great lung function, strong peripheral muscles, and is well-conditioned through exercise, they can outperform a sedentary kid who has a much better heart defect.
That's incredibly hopeful. It means the ceiling isn't fixed in concrete. It can be pushed.
It can absolutely be pushed. But it requires work. It requires intention.
Okay, so we have this snapshot. We know where everyone stands at a single point in time. But a snapshot is static and life moves. The study did something really crucial here. They plotted the data by age. They looked at the trend lines from age 10 all the way to age 18. And this is where the story shifts from, hey, look how great modern surgery is, to something much more ominous. We have a serious problem.
This is the age curve. And this is the part of the paper that keeps pediatric cardiologists up at night.
Walk us through it. What happens to a 10-year-old with, say, tetralogy of Fallot?
Okay, so in early adolescence, ages 10, 11, 12, even 13, the lines are pretty flat. Most of the diagnosis groups are maintaining their percentage relative to their peers.
So if they were at 85% of expected at age 10, they're still hovering around 85% at age 12.
Correct. They're keeping pace. Their fitness is growing at about the same rate as their healthy friends' fitness is growing.
So the parents, the doctors, they're all lulled into a false sense of security. He's doing great. He's stable. Everything is fine.
Exactly. But then puberty hits, and specifically the late teen years, 15, 16, 17, and the lines for the complex hearts, the Fontans, the tetralogy of Fallots, the complex valve repairs, the DORVs, they start to nosedive.
Nosedive? Is it that dramatic?
It's a steep, statistically significant negative slope. By age 18, the trend lines for all of these complex groups cross below the 80% threshold.
And 80%, that's the established cutoff for being deconditioned, right?
It's the danger zone. It's the point where functional limitations start to become apparent in daily life. It's a marker for increased risk later on.
Why? I mean, what is it about being 16 that just breaks the system for these kids?
The authors propose it's a perfect storm of three things. First, and maybe most obvious, is somatic growth.
They get bigger.
They get a lot bigger. You get taller, you get heavier, your body's surface area explodes between 13 and 18.
You turn into a man or a woman.
Right. And that bigger body demands more oxygen, even at rest. But the heart, the repaired heart, might not be able to scale up its performance to match that new, bigger body size.
It's a power-to-weight ratio problem.
That's a great way to put it. The chassis got too heavy for the engine. A Fontan circulation that worked just fine for a 40-kilogram kid might really struggle to perfuse an 80-kilogram young adult. The efficiency just drops.
Okay, so that's factor one. What's the second?
Factor two is body composition. The study cites a lot of prior research showing that patients with complex CHD, particularly Fontan patients, tend to have higher fat mass and, crucially, lower lean muscle mass compared to their healthy peers.
Why less muscle? Is it just from being less active?
It could be inactivity. It could be metabolic. It could be related to chronic low cardiac output. We don't fully know. But muscle is the engine that burns oxygen. VO2 peak is measured per kilogram of body weight.
Right.
So if a lot of your kilograms are fat, which doesn't really burn oxygen, and not enough of your kilograms of muscle, which does, well, your score tanks. You're carrying dead weight, metabolically speaking.
Okay. So bigger bodies, less muscle mass. What's the third factor?
The third factor is lifestyle, the psychological and social component. Think about high school sports. At age 10, everyone plays rec soccer. It's chill. You run around for a bit. You get a juice box and some orange slices at the end.
Everyone gets a trophy.
Everyone gets a trophy.
Yeah.
But at age 16, it's varsity tryouts. It's 2-a-days in August. It's intense, competitive, and specialized.
And the kid with the repaired heart who is maybe keeping up okay at age 12 suddenly realizes,
I can't keep up anymore. Or maybe the coach cuts them from the team. Or maybe the parents get scared and say, this is too much for your heart, and they pull them out. So what happens?
they stop moving.
They stop moving, they become sedentary, and when they stop moving, they get deconditioned.
Which makes their next stress test look even worse.
Which makes them even more discouraged and makes their parents even more worried. It's a vicious downward cycle. The late teen slide is partly physiological, the growth, the body composition, but it's also deeply behavioral.
It's just heartbreaking. You have these kids who fight so hard to survive infancy and toddlerhood. They do really well in middle school. And then right as they're supposed to be launching into adulthood, their physical capacity just crumbles.
It is heartbreaking, but, and this is the important part, it is also actionable. The whole point of this paper isn't to be depressing. It's to shine a giant spotlight on that slide so that we can prevent it.
Okay, so let's pivot to that, the so what section. What do we do with this information? The authors, Griffith, Wang, and Ward, are very clear that this isn't just data for data's sake. This is meant to change clinical practice, starting tomorrow.
Absolutely. The first and most immediate implication is what we can call the new dictionary. We have to stop using the bike charts for treadmill tests, period. End of story.
So if I'm a cardiologist or a pediatrician, I need to have the Griffith 2026 treadmill standards printed out and on my desk.
You do, or bookmarked on your computer. Let's go back to our tetralogy kid. He gets a score of 85%. If you use the old generic healthy kid chart, he looks below average. You might tell his parents he's a little deconditioned. But if you use the new Griffith chart, you see that 85% is exactly the 50th percentile for a teenager with tetralogy of Fallot.
So he's actually perfectly average for his condition.
He's average for his peer group. And that's a much more useful piece of information. It allows for a true apples-to-apples comparison.
And allows for risk stratification.
That's a key. If that same kid comes in next year and scores a 60%, now you know something is really wrong. He's not just lower than a healthy kid. He's fallen way off the curve for a tetralogy kid.
And that's a trigger.
That's a huge trigger. Maybe his pulmonary valve is leaking more. Maybe he's developing an arrhythmia. Maybe he needs an MRI or even a catheterization. The diagnosis-specific chart highlights the outliers who are in trouble. It stops the false reassurance.
It also creates a call to action for when we test.
Yes. The authors argue, very persuasively, that we need to start routine exercise testing early before the slide begins.
Get a baseline at age 10 or 11.
Or even 8 or 9. Establish where they are when they're stable. And for the high-risk groups, the Fontans, the Toffs, the complex valve repairs, we need to test more frequently through the teenage years.
Not just every 2 or 3 years.
Maybe every year. You want to catch that downward slope the moment it starts to tip. You don't want to wait till they're 18 and have already fallen off the cliff.
So you catch it. You see the slide starting at age 14. Their number has dropped from 85% to 78%. What's the prescription? Is it a new pill? Another surgery?
It's sweat.
Exercise.
The data provides powerful support for targeted aerobic exercise interventions.
You mean cardiac rehab?
Exactly. We usually think of cardiac rehab for, 65-year-old men who just had a triple bypass.
Right.
But the future of pediatric cardiology is proactive rehab for teenagers. Prescribed, supervised exercise programs.
Take 2 laps and call me in the morning.
It's a bit more scientific than that. But yeah, here is a structured program to build your lean muscle mass, improve your cardiovascular efficiency, and increase your oxygen extraction. If we know the heart can't pump more blood, we have to make the muscles more efficient at using the blood they get.
And this connects all the way back to the mortality issue we started with. This isn't just about feeling better.
No. In the adult congenital heart disease population, the data is crystal clear. Higher VO2 peak is directly linked to fewer hospitalizations for heart failure and longer life expectancy. Full stop.
So when we fight to keep that number up in a 16-year-old, we aren't just trying to help them make the soccer team.
We're trying to help them reach age 40, age 50, age 60. We're investing in their future survival.
The stakes just couldn't be higher. Now, I want to play devil's advocate for a second.
You're for it.
No study is perfect. Every piece of research has limitations. What are the holes in this one? What did the researchers themselves admit they might be missing?
There are a few important caveats. The biggest one, and they're very upfront about this, is medication.
You mean beta blockers?
Beta blockers, exactly. A lot of these kids, especially the ones with arrhythmias or signs of ventricular dysfunction, are on drugs like atenolol or metoprolol.
And what do those do?
They work by putting a ceiling on the heart rate. They prevent the heart from beating too fast, which can protect it.
Which is great for preventing an arrhythmia, but it sounds terrible for a stress test where the whole goal is to reach your maximum heart rate.
It's a major confounder. If a kid is on beta blockers, their heart rate might max out at 130 beats per minute instead of a more normal 180. That creates what we call chronotropic incompetence, and it artificially lowers their VO2 peak score.
So did the study control for that? Did they separate the kids on beta blockers from the ones who weren't?
They couldn't. Because it was a retrospective study looking back at old data, they didn't have reliable medication information for the entire cohort. So it is possible that some of these low scores are actually just beta blot scores.
The kids might be fitter than the number suggests.
They might be. And it's also possible that part of the late teen slide is simply more teenagers being put on beta blockers as they get older and develop more issues. It's a key limitation.
Okay, that's a good point. What about the Lurie effect?
The referral bias, yes. Lurie Children's is a world-class center. They get the hardest cases from all over the Midwest. They get the kids who have had failed surgeries elsewhere. They get the kids with complex genetic syndromes.
So this cohort of 887 kids might be, on average, sicker than the general population of kids with CHD.
It's very likely. If you did this same study at a smaller community hospital that only sees, say, simple BSDs and ASDs, the average scores might be higher. This data set probably represents a fairly high-risk group.
And you mentioned genetic syndromes. They didn't exclude those?
No. They didn't exclude kids with Down syndrome or DiGeorge syndrome or 22q11 deletion. And we know those conditions can have their own musculoskeletal or metabolic limitations on exercise that are separate from the heart itself. So that muddies the water a bit.
But even with all those limitations, the meds, the referral bias, the genetics, the main signal from the study is still strong, isn't it?
The signal is undeniable. The noise of the limitations doesn't drown out the main melody, which is the ruler was wrong, the treadmill is the better test, and the late teen decline is a real and present danger we need to address.
I want to circle back to something we touched on a little earlier, the muscle mass issue.
Okay.
The study mentioned that Fontan patients often have less lean muscle, and you said that a potential therapy is improving muscle efficiency.
Right.
It sparks a provocative thought in my brain. For the last 50 years, cardiology has been obsessed with the pump, the heart.
Sure.
We fix the valves, we patch the holes, we give drugs to make the muscle squeeze harder or relax better. It's all about the pump. But if the bottleneck for these kids is happening in the muscles, is the future of cardiology actually in the weight room?
I think you were hitting on the next frontier of heart failure therapy. We call it the skeletal muscle hypothesis.
Skeletal muscle hypothesis.
Yeah. If the heart is a weak pump, we can't always fix that. We can't grow a new ventricle, not yet anyway. A heart transplant is a last resort. But we can grow new muscle on the legs and arms.
We can build a better chassis to go with the engine we have.
That's it, exactly. If you increase the muscle mass in your legs, and more importantly, you improve the mitochondrial density in those muscles through training, they become much better at sucking oxygen out of the blood. They become more efficient.
So the heart doesn't have to work as hard to do the same amount of movement.
Precisely. If your muscles can extract 80% of the oxygen from the blood that passes through them instead of 60%, that's a massive load off the heart. The heart can achieve the same level of activity walking upstairs, carrying groceries, with a lower cardiac output.
So instead of telling these kids, be careful, don't overdo it, you're fragile, we should be telling them, go lift some weights. Safely, of course. Get strong.
Obviously under medical supervision and with proper guidance, but yes. Resistance training, which was taboo in cardiology for a very long time, is coming back into favor in a big way. We now understand that strong muscles support a weak heart.
It just completely changes the narrative. It shifts from you are fragile because of your heart to you need to be strong because of your heart.
It's incredibly empowering for the patients. It gives them a measure of control. You can't control the anatomy you were born with. You can't control the outcome of your surgery, but you can control your squat. You can control your bicep curl.
That is a powerful, powerful place to land. We've gone from broken rulers all the way to gym memberships as a form of cardiac therapy.
It's been quite a journey.
So to recap for everyone listening, if you have a child with CHD, or if you're a clinician who treats them, number 1, ask for a treadmill test, not a bike test, if it's safe and appropriate.
And understand what it's measuring.
Number 2, compare the results to these new Griffith 2026 standards, not the generic old ones. Know what average really means for your kid's specific condition.
Context is everything.
Number 3, watch that age 15 to 18 window like a hawk. Be proactive. Don't wait for the slide to become a cliff.
Intervene early.
And number 4, don't fear the gym. Embrace strength. It might be the best medicine we have.
Couldn't have summarized it better myself.
Thank you to Griffith, Wang, and Ward for this incredible piece of work. This is the kind of research that really changes lives. And thank you to you, the listener, for sticking with us through all the physiology.
Knowledge is power, and that's especially true when it comes to the heart.
We'll see you on the next deep dive. Keep those engines running.